Hi everyone, I'm Philippe Havard, Global Head of Marketing for Lipayodol in Guerbet. I would like to thank you to attend these sessions, and I would like really to thank Geert Maleux to have accepted to present this lymphangiography technique. And I wish you all the best for these sessions. And of course, don't hesitate to ask your questions on the question part you have on the right of the screen. And Geert will answer these questions after the presentations. Thank you very much. Geert, floor is yours.
Okay, thank you, Philippe, for this kind introduction. And indeed, in this presentation, I will focus on lymphangiography technique. These are my disclaimers. And okay, so if you want to map the lymphatics, in fact, we have two options. You can do it by MRI, and therefore we need some gadolinium-based lymphangiography, or you can do it by X-ray, and then you need Lipayodol to opacify the lymphatics. When you do it with Lipayodol, well, in the past, this was done by an intrapedal access. However, today, more and more centers are now doing an intranodal access to the lymphatic system. What does it mean? Well, with a fine needle, it's like a spinal needle. Under ultrasound guidance, we puncture here the hilum of a lymph node in the groin, for instance, and then we very slowly inject then the Lipayodol through this spinal needle, and then you will see the slow pacification of the lymphatic vessels. And then third, you can do it also by direct puncture of some larger lymphatic systems like the thoracic duct, or in cases of dilated lymphatic vessels, for instance, in the liver. There is also increasing indications for lymphangiography and endolymphatic intervention. And from an historical point of view, the first indications were traumatic and non-traumatic chylothorax. But nowadays, we treat also do some lymphatic situs treatment, and also some postoperative lymphoseals. And more recently, especially then in patients with congenital heart disease, we try also to diagnose and to treat patients with plastic bronchitis and protein-losing enteropathy. So as I already said, one of the first indications for diagnosis and also treatment of lymphatics were these chylous, chylothorax. This chylothorax can be traumatic. Traumatic, in most of the cases, means related to surgery, but you can have also sometimes some non-traumatic chylous effusions, and the technique for diagnosis and treatment is more or less the same. Well, as I already said, you can do an intrapedal access, or nowadays we do more and more intranodal access from the groin. And then once we have opacified the whole lymphatic system from the groin up to the thoracic duct, well, then you can make your diagnosis of most of the cases of chylous leak. Here in this case, for instance, this was a patient after a lobectomy for a malignant lung cancer at the right side. Well, this patient presented with some refractory chylothorax despite already some 2 surgical reinterventions. And when we here opacified the thoracic duct here in the lateral view here, then you can see indeed that the thoracic duct is nicely patent. However, here in the proximal and anterior part of this thoracic duct, you see some leakage, and this was indeed the leak which was responsible for the refractory chylothorax. How to treat, well, these leaks? Well, in fact, we have to close then the thoracic duct, and of course, therefore, you can do it on several, there are several techniques. First of all, what we did here was to confirm the leak by these cone beam CT images, where you nicely can see here really the leak and the relation of the leak to the thoracic duct. And then by direct puncture, you can do this blindly or under a fluoroscopy, or even like here in this case, under cone beam CT guidance. You can then introduce a guide wire and a microcatheter into the thoracic duct, and then you can coil and or glue this thoracic duct. However, there are also some cases, especially in these postoperative cases, and one of the typical examples is in these patients with a resection of the esophagus. So after esophagectomy, then not only the esophagus has been resected, but also the thoracic duct. And that what you then see here is all these abdominal lymphatics, and then these abdominal lymphatics, instead of draining the lapidal into the thoracic duct, no, this is draining them in these small collateral lymphatics, and these small collateral lymphatics can also be injured by surgery. And here you can see on several in several collaterals which were damaged by the surgery, and they were responsible for the the chylothorax. What you can do then is to impregnate, infect all these collaterals, which as much as possible of lapidal, so that you have a kind of saturation of these vessels, of these lymph vessels with lapidal. And this lapidal will not only show you the area of leakage, but will have also a kind of sclerosant and occlusive effect, and then it will also stop the leakage. And these are then the corresponding CT images 1 day after the procedure, where you cannot see the thoracic duct because the thoracic duct is ligated. But you can see here indeed these leaks, these leaks of lapidal into the left pleural region. Indications in the abdomen. Well, we can diagnose and treat chylous ascites and also postoperative lymphoceles, and this has been also published by the Philadelphia group, and also by a few groups from the Far East, like the group by Hur in Seoul, South Korea. And I will start with an example. This was a 76-year-old patient with a bladder replacement surgery, and postoperatively there was a large lymphocele at the right side. It was already a pigtail placed in that lymphocele, but there was a continuous, persistent production of lymph in that through that drain. So what we did here, again, we did a intranodal approach. We injected then slowly lapidal into that lymph node. Then you see the lapidal going into the lymphatics. More and more lymphatics, and what you see here is some contrast, some lapidal extravasation into the lymphocele, because as you can see, it is in close contact to that pigtail catheter. And if you wait a little bit longer, then you see more and more lapidal going into that lymphocele. Then you know, of course, where are really the areas of lymph vessel injury related to surgery. And again, here there are two possibilities to treat, and I will come back on that treatment. But first, another case. This was a young patient, a 41-year-old woman with a juvenile diabetes, underwent a kidney and pancreas transplantation, and presented then with a very large postoperative or post-transplant lymphocele at the left side. This was one of our first cases, and in that time, well, surgeons, our transplant surgeons, performed a laparoscopic fenestration. But however, today we will go immediately for interventional radiology. But the result of that defenestration was that we did not have anymore a lymphocele, but now a chylous ascites. How to treat, again, this has been published already by Williams and co-authors. We punctured the left in the left groin a lymph node. We injected very slowly the lapidal. And again, after injection of more than 10 cc of Lapidol, you see this large amorphous area of Lapidol. This is indeed the leak, so the Lapidol extravasation, which was indeed responsible for the initial lymphocele and secondary also for the chylus ascites. How to treat? Well, there are two possibilities, and then I will go back one slide. Well, how to treat, or you can, again, like in these thoracic cases, you can inject as much as possible of Lapidol, which will have also a kind of saturation of these vessels and the leak with Lapidol, or you can inject a mixture of Lapidol and ambicrylate. Typically, we use a ratio of 1/4, 1/5 to occlude these lymphatic vessels so that so the lymphocele will be treated immediately. There's one difference in between these two techniques. When you inject the mixture of Lapidol and ambicrylate, you have to know this might be painful for the patient during the injection, which is not the case when you should use Lapidol without the ambicrylate. Okay, now we will move again to the thorax. And then, well, there are also some very quite new indications to use these lymphangiographies, both for therapeutic and both for diagnostic for therapeutic purposes, which is these lymphatic pathologies and heart disease, especially in patients with Fontan circulation. That means that we typically do these procedures in young patients, meaning in children and in adolescents. Like in this patient is a 16-year-old boy with Fontan circulation and has now some plastic bronchitis. What does it mean? That he has some fibrinous cast impaction in one or both lungs. And as you can see here, this was one of these casts of fibrinous material. So what we did here, again, we did the opacification from the groin of the thoracic duct, and also these hypertrophied lymph nodes in the mediastinum, which are in connection with the lymphatic duct. And that you can do, well, initially we did this with Lapidol, but today you can do this also by MRI images. And again, the same technique with a spinal needle. We do the puncture of a groin lymph node, and then we slowly inject 5 cc or at both groins. That means in total 10 cc of gadolinium. And then we will have the same opacification. Once we have identified the thoracic duct and these hypertrophied lymph nodes in the mediastinum, we then refer the patient to the interventional radiology suite, and we did a direct cone beam CT guided puncture of these enlarged lymphatic nodes in the mediastinum, and then we injected there then the mixture of Lapidol and ambicrylate, well, really to occlude these extravasation of lymph material from the thoracic duct into the bronchial tree. And then another pathology, what we treat now also more and more, is patients with protein-losing enteropathy. What does it mean? Again, typically in children and adolescents with failing Fontan circulation, that these patients have a lot of edema. They are losing a lot of proteins into the bowel, and they are treated with a lot of drugs like cardiac drugs, to treat these or to try to stop this protein losing enteropathy. However, that does not work in most of the cases. So what we do then, we know that there is a spillage of proteins coming from the liver into the duodenum. So if we can stop the drainage of lymphatic material from the liver into the duodenum, then we can treat these patients. That's the reason why we do then, under ultrasound guidance, we try to puncture then the wall of the portal vein, and we do this typically with a Sheba needle. Once we guess we are into that lymphatics, which are really located in the wall of that portal vein, we very gently and slowly inject some iodized contrast medium to confirm that the correct positioning of our tip of the needle. Then we rinse our needle with D5, D10 glucose solution, and then we prepare for injection of a combination of glue and of ambucrylate and lapidol, again in a ratio of 1/4, 1/5. And then what you see here on this slide, the right sided image here, this is indeed all these lymphatics draining the liver into the proximal bowel, so the duodenum, through these enlarged, and you even see some lymph nodes in that area. But by occluding these lymphatics here, then we will stop also the spillage or the loss of proteins into the bowel, and patients will stop having this protein losing enteropathy. And when we look to the results, then we see on the short term that in most of the occasions we can reduce or even stop all the drugs which were given or administered to treat this protein losing enteropathy. However, this has been published by the Philadelphia group. In some of these patients, this effect might be temporary, which means after a good response, there will be a relapse of their protein losing enteropathy. However, what we have seen is that after such a relapse, this is again a good indication to retreat, and it is also technically very possible to retreat these patients. That means that in more than half of the patients, in our experience, we did over, let's say, and now we've an experience of more than 5 or 6 years, that we treated well, nearly half of the patients twice, or even in patients will have had 3 sessions. But the end result is that even after 2 or 3 sessions, still these patients are free of protein losing enteropathy, and this is, I think, the very good news. So in conclusion, let's say there are today more and more diagnostic procedures to opacify the lymphatics, both with use of MRI or both with use of X-ray. When you do it with MRI, then of course you need gadolinium-based contrast media. When you do it under X-ray, then you have to use lapidol. These techniques are feasible, they are very safe, and they're also reproducible. And I think that today there is more and more clinical evidence to perform this in daily life, these procedures, not only from a diagnostic perspective, but also from a therapeutic perspective. And this is, at least in our hospital, more and more accepted by several specialties, not only thoracic surgical specialties, also abdominal surgical specialties, transplant surgical specialties, cardiology, and probably this is only the beginning of let's say, of a new entity, which I call the endolymphatic interventions. I thank you for your attention.
Thank you very much, Geert, for this very interesting presentations. I have some questions for you. The first one is, do you have any tips for puncturing the thoracic duct? How do you prevent the duct from collapsing?
Well, you have to puncture the thoracic duct there where is the largest. And what you can do is, of course, we try to avoid to puncture directly into the thorax. What we like to do it, try to puncture the cisterna chyli, which is in the upper abdomen, which is also larger than the thoracic duct and easier to puncture. That might be quite an aggressive approach because you do it not really blindly, but you have you do it under fluoroscopic guidance. And you do the puncture with a Shiba needle, which is a 23, 25, even 27 gauge needle. This is a very fine needle. And also the Bonn group, they recently published a paper on are the side effects or the collateral damage of such a puncture. Well, and the good news is that, well, of course, you might have some infectious complications, or you might have some local damages. For instance, when you go through the pancreas, you might have some mild pancreatitis. However, they've never seen big bleedings or other, let's say, serious adverse events related to the puncture of the cisterna chyli and the catheterization of the thoracic duct.
Thank you, Gert. As other question, what would be slowly inject? Do you use a pump, a syringe, or a manometer?
Well, you can use a manometer. I think that the Philadelphia group that they like using an inflation device, well, just the same device as you use for inflating an angioplasty balloon, and then you can very slowly inject your lapidol through that system. I typically do it with a syringe, but I use a connection in between the spinal needle and my syringe. And as a syringe, I typically use then the Victoria system, which was brought on the market a few years ago by the Gerbet company. Why? Because this Victoria system, well, they are compatible with lapidol. Yeah, when you should use another regular type of syringes, then these syringes might really break when after a while, when it's filled up with lapidol. But again, we slowly means that you do it under X-ray guidance, of course. And slowly means that you see then really the progression on X-ray guidance of your lapidol, and that's in most of the cases enough. Another maybe important point is that, of course, even if you do it slowly, you might have sometimes some leakage at the groin itself, meaning that lapidol might extravasate a little bit out of your lymph node, which you punctured, you targeted with your spinal needle. But in contrast with iodized contrast medium, I've never seen, we've now already done more than 100 of these procedures. We've never seen some pain complications due to the extravasation of lapidol, which is in contrast to the iodized contrast medium. Once you have extravasation, that's quite painful. But with lapidol, we've never seen this complication.
Thank you, Gert. Other question, do you puncture peripheral or central portal vein for protein-losing enterotherapy?
Yeah, well, let's say that you have to occlude the lymphatic communication in between the liver and the duodenum. So that means, and that the better is as a target that you try to target the largest lymphatic vessels. And where are the largest lymphatic vessels which are reachable by direct puncture under ultrasound guidance? Well, this is in the proximal right portal vein. That means that the proximal right portal vein is your first target to do the puncture. If but sometimes, and we have seen this, let's say that you did the first session, you targeted your right proximal portal vein, and you occluded all these lymphatics. But after 6 months, after 1 year, there is a relapse of symptoms of protein-losing enteropathy, of course. Then your access at the right side, at the right liver lobe, might be already occluded. Sometimes there might you might have a formation of new lymphatics, but if there are no let's say new lymphatics which can be targeted, then you can go also, you can do also the puncture at the proximal left portal vein. And in most of these patients with protein lesion enteropathy, because of the pathology, the failing Fontan circulation, they will have also have big livers, which means that from a technical point of view, the puncture of your left proximal left portal vein is not that difficult. You don't have to do it by a transcostal approach. Normally, a transabdominal approach is enough because these livers are so large.
Thank you, Gert. In case of present of right to left cardiac shunts, what contrast agent will you use? Do you still use lipoidal?
Well, and that's indeed a good question. So when we have, and this is especially then for patients with plastic bronchitis or thoracic indications, we try to do, well, you can, of course, exclude the presence of a right to left shunt by cardiac ultrasound. I think this is that you have to do it always. Huh? But if you are not sure if there is still there's still some debate with your cardiologist, then I should advise to do it by MRI. And because when you have an MRI, then of course there is no risk of shunt, because if you might have a droplet shunt, droplets of Lapidol, then you might have some paradoxical embolism with some cerebral, for instance, cerebral complications. That's correct.
Thank you. Do you place a sheet after puncture of the chile?
For which indication? For thoracic indications or for abdominal indications?
Is not
well,
precise. Right?
Yeah, well, in general, you do not have to place a pigtail or another catheter or a drainage catheter before you start the procedure. However, for lymphoceles, for instance, well, as I showed you a few of these examples, well, and also for thoracic, for chylothorax, these patients, they already have a drain because of as a first attempt to treat these pleural effusions. So these pleural effusions are firstly treated by thoracic drains, or the lymphoceles are firstly treated with a pigtail catheter, but then the clinician will see then that it's chylous material which is drained, and then this is then of course the indication for a referral to IR. Of course, that at that time these patients will have these drainages in place, or these drains in place. But let's say it's not. You can also start immediately your lymphangiography, even if the patient should not have these drains in place.
And probably you mentioned that, but maybe good to remind, which needle do you use for punction of the nodes in the groin or in the abdomen?
Yeah, well, for if you want to puncture the lymph nodes in the groin, I typically use then a spinal needle. It's a 23 or a 25 gauge spinal needle. This is more than enough. You don't use too large needles. This is a very fine needle. That's more than enough. If you want to do a liver lymphangiography, of course, the distance in between the skin and the wall of your right or left portal vein is larger, is longer in most of the cases. Even in children, it's longer than the length of your spinal needle. So in these cases, we typically use a Shiba needle, which is has a length of 20 centimeters. Of course, you can use also this Shiba needle also for groin incision, but it's more handy to use a very short spinal needle.
Thank you, Geert. The last question, because one of the attendees who asked question lost the connection. Would you mind to explain again which contrast agent you would use for the right-left cardiac shunts? And thank you, and sorry because he lost the connection.
Yeah, well, for right left to exclude a right left cardiac shunt, well, first of all, you have to ask for an cardiac ultrasound, because your cardiologist will, in most of the cases, will do this well by cardiac ultrasound, and then he can confirm or exclude a right to left shunt. If your cardiologist is not very sure at all, then of course I should do an MRI, gadolinium-based MRI lymph angiography, because with MRI there is no risk of paradoxical embolism, which might be the case if you should use directly and without having checked the right or left shunts, when you should directly go for a lapidal-based lymph angiography.
Thank you, Geert. The last question, because we are just on time. When you presented thoracic duct, you discussed about guide wire and microcatheters. Which size for both?
Well, the easiest let's say guide wire to use is a coronary 0.014 guide wire, because this goes through these fine Shiba needles. You can also an 0.018 like a V12 wire from the Boston company, but also other coronary wires are very effective. And over that coronary wire, because they are much more rigid than the micro guide wires which you use in combination with micro catheters. Well, over that coronary wire at 0.014 or 0.018, then you can gently introduce a micro catheter without sheath. So immediately a micro catheter over that 0.014 wire. That's a technique.
Thank you very much, Geert. So we have arrived at the end of the talk. So I would like really thank you again for this excellent explanations and technique details regarding this angiography. And I would like to thank everyone who were connected with us today. Next session this afternoon at 4. So if you want to have some reminder, for example, for those who connected right now, next session this afternoon, 4 o'clock. Thank you very much, Geert, and I'll see you later.
Bye.
Thank you very much.
Bye.
Bye.